And the last question was, I read in the New York Times that doctors are seeing that COVID is acting differently than they thought and kind of uniquely from a respiratory perspective. Can you give us some commentary on this? So I've given a disclaimer every time I've talked about COVID. I'm going to give that same disclaimer, which is that I'm doing my best to kind of, share information, but this is a changing and evolving situation. And so this is just little me doing my best. But this disclaimer is even heightened given the question because I am not in the ICU and I don't have firsthand experience to talk about this, but I feel very comfortable talking about general principles and helping you guys understand the more granular nature of this. And I will do that. Okay. So I pulled out some of my children's stuff to be able to help explain some of this. So first, let's just start with a premise that I think all of us can agree with, which is that it is not good to have low oxygen levels in the body, right? We need oxygen to live. And when we have low oxygen, that's not sustainable for life once it gets to a certain level, okay? So once we accept that premise, low oxygen in the lungs is referred to as hypoxia. That's the medical term, is Hypoxia. So there are a couple of different mechanisms of hypoxia that we are kind of more familiar with, okay? The first one is referred to as the VQ mismatch. So that V is for ventilation, air, Q is for flow or blood. So play along with me that red is blood, okay? And blue is flow. This is your oxygen flow, okay? So let's say you've got enough blood, like you've got an X amount of blood, and you've got the same amount of oxygen. You're okay, right? Like you're gonna oxygenate really well, and this is gonna go well. You're gonna send this to your tissues okay, and it's gonna go well. But let's say you've got blood, but you don't have as much oxygen, right? Look at all this like blood that is not getting oxygenated. This is referred to as the VQ mismatch. Now, what we do in this situation clinically is we give 100% oxygen to this person and we make up that difference, right? So now they're back to 100% oxygen and therefore they can oxygenate their tissues well. The second kind of hypoxia is referred to as a shunt phenomenon. And here, this is not exactly right, but essentially it's kind of like the blood and flow is about the same. It's not as big of an issue, but the bigger issue is the alveoli. So this is my balloon. And remember, the alveoli are the little cells that are actually doing the gas exchange, okay? So in this situation of a shunt, I'm just making sure you guys can see me, what's happening is that this alveoli is actually totally contracted and like shut. So if I give 100% oxygen, it doesn't actually matter because this alveoli is closed for business, so to speak, right? So instead, I give oxygen, but I also give ventilation. I give pressure, which is what a ventilator does, to open up this alveoli so that gas exchange can happen more effectively. Does that make sense? Okay, so those are the two types of hypoxia that we're used to and that, may not go perfectly, but typically respond to interventions that we have in our toolbox. What we're seeing with COVID is that this is not always how it goes. It's actually a little bit different. People don't look like this when they come into the ER. And in fact, curiously, instead of being in respiratory distress and maybe even unconscious, they are sitting upright, they are talking on their cell phones, and they don't look like they're in distress at all, okay? And the reason for this is because this type of hypoxia is what's called silent hypoxia. So the mechanism here is, so we've got our gas exchange, we have our alveoli, and really, my hair clip is going to demonstrate this, there is a barrier to the alveoli, okay? So in this situation, it's difficult for oxygen to get in, but it can get in, but it's just difficult to get in. And interestingly, carbon dioxide, because of its molecular weight, can leave the lungs just fine. So what does this mean? This means that we're not getting enough oxygen in, but we're expelling carbon dioxide okay. So let me make a side note about this. Usually, when we're short of breath, it's because we have a buildup of carbon dioxide in the lungs, and it signals receptors to say, we're getting dangerous, and we feel short of breath, okay? But in this situation, remember I told you, actually carbon dioxide leaves the lungs totally fine. So that feeling of shortness of breath is not necessarily happening for everyone, right? And that's important because even though that feeling of shortness of breath is not happening, your oxygen saturation is still going down during that time, right? And this is why doctors are saying, I've never seen anything like this. A woman is chatting upright, her oxygen saturation is in the tubes, and I'm running in to intubate her while she's like on Instagram, basically, right? That's not a scenario that is typical for doctors. Usually someone is semi-unconscious or on their way or having massive respiratory distress, then they get intubated, then they get put on a ventilator. So this is really unique. And I think this is important because additionally what happens, so let's say you have COVID, you don't feel short of breath, what you do to compensate is to start breathing really fast. To get more oxygen in, you start breathing really fast. And if you think about that, you're putting a lot of work on your lungs, right? And just like you would kind of like work out a muscle and that muscle might get tired, it may not be exactly the same, but the same concept is true, that the lungs are getting tired. So well before you even potentially show up to the hospital, you're low oxygen and your lungs are exhausted, right? And, you know, I know this sounds negative, but I think the positive in this is for us to continue to track this, because if this really turns out to be, you know, kind of a more dynamic and consistent feature, then this is helpful, right? Because we can intervene sooner, we can have tools to help people sooner, because the other additional thing that's happening here is there is this observation that ventilation is not always helping COVID patients. And what doctors have been doing is actually putting patients prone, so on their bellies. And what happens when you do that is very simply, you just like increase the like flexibility and loosey-goosiness of the lungs so that they can respirate better, okay? And this is great. If this turns out to be something that is useful, we'll need less ventilators. We'll also have less demand on resources as far as doctors and nurses and laboratory, and we can kind of, for lack of a better way of put it, you know, move people in and out of the hospital with more ease. So, you know, that's kind of the stuff that's being looked at and kind of the emerging thinking around this. It's still evolving, obviously. As two side notes, I think in the New York Times there and in many other newspapers, there's this kind of recommendation to own a pulse ox, right? So a pulse ox is that little guy, when you go to the doctor, you stick your finger in and it can measure your oxygen saturation. Now, I will say, given that it was in many newspapers, if you try to go online right now and buy one, you will probably not find one, and I do not want you to panic about that. But, you know, I do, if you want my thought about this, I don't think it's a bad idea to own one, especially as we start easing up on social distancing. It may be one other way for us to kind of just assess how we're doing if we know we have an exposure, if we're feeling sick. It's one other kind of data point that we can have. If our oxygen saturation is starting to go down, we might say, okay, this kind of raises my alarm a little bit more. It's one more kind of factual piece of data. That being said, you may not get a pulse ox. And another thing that you can do, hopefully not obsessively, is to just know what your respiratory rate is, right? So we all have kind of a natural respiratory rate, and it might be useful to just like one time figure out what your baseline respiratory rate is. So that's how many breaths you take in a minute. And if at any point as this unfolds, you start to notice either that your respiratory rate, and there's context, right? There's more than just your respiratory rate, because it can also increase in stress and anxiety, but there's other context that makes you think you might want to pay attention. You can notice if your respiratory rate is rising from what your baseline is, and certainly if you get around mid-20s or 25 plus, that's a sign that we need to be more concerned. Okay, so that's just another like little FYI, a little tool that you can put in your pocket that might be helpful. And then lastly, and I hope I'm not going on and on about this, but lastly, you know, there is some thinking as we kind of evolve, as we're knowing about COVID, that this, right, like this guy, as I've said before, we've talked about oxidative stress, that some of the mechanisms for that barrier are related to oxidative stress or tissue damage, free radical damage. And the thinking is that there is some specific damage that's happening to hemoglobin, which is part of the cell's oxygen carrying capacity. And interestingly, it's why, if you think about malaria being an attack on hemoglobin, it's why we're starting to, we think, it's why we're starting to see that, at least in some cases, and there's some preliminary data that those anti-malarials are helpful because they're supporting that hemoglobin molecule, okay? I think that's all I have to say about that. So those are the questions for tonight.